Thank you, Dr. Sham and Dr. Kaul, for inviting me. Before I start my talk, I think I already have a supporter. Geeta has already talked about de-escalation of the XLR post NACT. So axillary node dissection has always been an important component of breast cancer treatment. In the Hestadian era, ALND was regarded as an important procedure to ensure regional control. With the evolution of therapeutic concepts and introduction of biological approaches, the goal of ALND shifted from a purely therapeutic procedure to a diagnostic and staging procedure, and thus guiding further treatment and some therapeutic effect in node-positive patients. I think Cody wrote long time that sentinel node localization is the second most important development in this century after conservative lumpectomy for the treatment of early breast cancer. And Cady in 1984 wrote that lymph node metastasis may be an indicator, but not governors of survival. In fact, 30 years back, my dear senior colleague and friend Dr. Indranil Mitra spoke once that lymph node metastasis may always not be a bad prognostic factor. It may be a chronological age of the disease. And why it is so? Because we know that shedding of cells into the vascular and lymphatic vessels undoubtedly occurs simultaneously in the vast majority of cancers. But the later progressive growth of cells and micrometastasis distributed hematogenously to vital organs is the ultimate governor of survival. Coming to my topic, that sentinel node biopsy post NACT, and I am speaking for the motion. So let us see what are the indications of today neoadjuvant chemotherapy. We know that till a decade back, only the locally advanced breast cancer was the indication of neoadjuvant chemotherapy. But today, any lesion which is more than 2 centimeters, if it is TNBC or HER2 positive patients, they are an indication of neoadjuvant chemotherapy. And what are the situations that sentinel node biopsy can be done? Somebody asked also that we can do sentinel node biopsy before starting neoadjuvant chemotherapy. We can do sentinel node biopsy in clinically N0 nodes on presentation. And when we say clinically N0, it means clinical imaging, and today ultrasound FNAC of the lymph nodes has become a very, very important part of the pre-treatment workup for axillary nodes. And of course, the clinically positive nodes on presentation post NACT, they become clinically N0. So they are the indications for sentinel node biopsies. And how we judge that whether we should do sentinel node biopsy in all the cases or not, the issues are identification rate, false negative rates, and axillary recurrence and survival benefit. So let us do the first situation, that whether we can do sentinel node biopsy before starting chemotherapy or after chemotherapy in N0 patients. So these are the 4 trials which has been done, that where the sentinel node biopsy has been done before starting the neoadjuvant chemotherapy, and down is the 4 trials where they have done a sentinel node biopsy after the neoadjuvant chemotherapy in N0 patients. And there is a large body of data demonstrating that in clinically node negative patients performing sentinel node biopsy before or after NACD results in the same identification rates, that is almost 85 to 97%, and same false negative rates ranging from 5 to 12%. And these results are similar to other prospective multicenter trials. So today, by and large, the sentinel node biopsy is not done before starting the neoadjuvant chemotherapy, because patient unnecessarily goes for 2 surgeries. So in a clinically N0 node on presentation, most of the time, the sentinel node biopsy is done post NACT. And so I think there is no disagreement over post NACT sentinel node biopsy in N0 patients. So coming to the next, which is the most debatable and controversial topic, that is sentinel node biopsy accurate when nodes are positive and the patient received neoadjuvant chemotherapy. In a meta-analysis, there are about 13 trials, but most often we quote 3 major trials on this issue. And first is Z107 trial, where the initial false negative rate was almost about 12.6%. So that is a little less acceptable because arbitrarily the investigators have put a limit of the false negative rate to 10%. But then how we can decrease the false negative rate? When we do a two-agent, by the blue dye and radiocolloid, FNR came down to 10.8%. And when we do at least 2 or 3 sentinel nodes, the FNR rate comes to 9.1%. Another trial where Sentinel trial, not Sentinel trial, where the false negative rate was 14%. But again, when we examined more than 3 lymph nodes, the FNR came down to 10%. And with the double mapping, the FNR rate came to 8.6%. Similarly, this Canadian trial, again, the overall FNR rate was 8.4%, but it came down to 4.9%, or even a dual tracer technique about 5 to 2. So if we select our patients properly, if we do a proper technique, I think our false negative rate can come down to less than 10%. And this is the same slide, the sort of summary and comparison, what was the false negative rate initially and how the false negative rate can come down. This is another thing that Geeta has already talked about, a targeted axillary dissection, where we put a clip or radioactive iodine sheets in the node at the time of FNAC. And when we do sentinel node, we remove these nodes also, and false negative rate can be brought down to as low as 1.4%. Next is, as I said, the issue is axillary recurrence. So these are the 2 trials, NSABP04 trial and NSABP32 trials, where the false negative rate of sentinel node was about 9.8%, but the axillary recurrence was only 0.7%, while in the NSABP04 trial, 40% of patients had axillary metastasis, while the axillary recurrence was observed only in about 18% patients. Similarly, a meta-analysis of several randomized trials of ALND versus no surgery in the axilla, the axillary recurrence rate varied from 1.8 to 3%, while the pathological node disease was found to 21 to 28%. What I mean, if we do axillary dissection, the disease in the axillary nodes may be higher, but that does not represent clinically in the long run in the follow-up as axillary recurrence. And this is, we all know that today, if we do a frozen section on the sentinel node, and if the sentinel nodes are less than 3 positive, we may not offer complete axillary dissection. And these are the 2 trials, Z0011 and IPSCG trials, where there was no significant difference in either disease-free or overall survival within the study arms, despite the fact that involved axillary nodes were detected in more than 27% of those who underwent complete axillary dissection. And next is, do we offer survival benefit to these patients? And we know that 25-year follow-up of a randomized trial comparing radical mastectomy, total mastectomy, and total mastectomy was followed with radiation. There was absolutely no sort of survival benefit. So these are the just basic trials of sentinel node biopsy, where the sort of false negative rate was fairly high, but there was no survival difference. So that is what my message is, that there should be a sentinel node should be tried today in clinically N positive patients who become N0 patients after NACT, but we must make some effort to reduce the false negative rate of sentinel node by at least dual mapping, 2, 3 or more sentinel nodes to be removed. If possible, pre-treatment positive node should be marked, and of course use of immunohistochemistry on the sentinel node. And even NCCN guidelines 2022 also says that if preoperative chemotherapy has been given, then sentinel node in selected cases when nodes clinically become negative should be tried. A meta-analysis of sentinel node biopsy after neoadjuvant chemotherapy in patients with initial biopsy proven node positive breast cancer. The sentinel node is fairly accurate and reliable with careful patient selection and optimal surgical techniques and shall become a standard practice in due course of time. So my take-home message is the centers which can have these facilities, which can have a dual technique, and of course a good frozen section on sentinel nodes and correct selection of patient and correct technique, I think we should start practice sentinel nodes in clinically and positive NACT and then becoming clinically and zero disease. Thank you.